My journey to work to close the global pain divide started when I was 18. I was with my father, who was dying of a concentration camp-related stomach cancer, on the 17th floor of Mount Sinai Hospital in Toronto. It was the last days of his life. He had suffered terribly, and by this point, he could no longer speak. I asked him if he was in pain, and he squeezed my hand. So off I went to speak to the residents and physicians and ask for more pain relief medication. And they said, sadly, they couldn't give it to me because it would hasten his death. He kept squeezing my hand, and I persisted and insisted that we needed more pain relief medication. So on that last night, 2 of his injections came closer together, and some medication was left beside his bed, and I gave him that medication, and he was in peace a few hours later and passed. Fast forward many years later, I'm working on improving access for women with breast cancer to chemotherapy. And I go to visit one of our pilot projects and one of our patients, Doña Lucinda, in a small secondary level hospital in Ciudad Guzman, about 2.5 hours from the capital city of Jalisco. And we come in, my oncologist and I, Dr. Julie Graylow, to see our patient, and Julie says, this patient does not need chemotherapy. She is at the end of life. She was there with her 17-year-old daughter. She had brain metastases, and they had managed to bring her there to get care. In came the heads of the hospital, and when they heard she needed palliative care, they said, not here. Figure out a way to take her to the capital city. And at that point, her daughter began to cry. There was no way to move Doña Lucinda to where they were saying she needed to go, and she didn't need to go there. But Doña Lucinda and her daughter taught me many things. I had just published a paper in The Lancet, the leading medical journal in the world, saying that Mexico had achieved universal health coverage. And I realized that we had forgotten to include palliative care and pain relief. Now, how did we forget? And at that point, I was also leading a non-governmental organization that my husband and I founded to support women with breast cancer, an organization called Tómatelo a Pecho. We were advocating and helping women to get access to care. But when I walked into Doña Lucinda's room, I felt fear and repulsion. I had the same disease she did, and I was worried I would die too. But I wasn't going to. I was much luckier. And that was the point at which I realized that many of us who do advocacy around cancer are rejecting those who are not going to survive their cancer. We put up these false divides and divisions between the survivors and the not. And that led us to think very carefully about what had to be done to increase access to palliative care and to link patients. And we started a Lancet Commission, that leading medical journal, a global commission on access to pain relief and palliative care, with over 60 researchers and leaders from around the world, including my co-chair, Dr. Paul Farmer, and representing countries from every region. We began to work and produced the report that is freely available, and you'll see the QR code on screen. The cover of that report is another woman who taught me something very important. This abuelita, we met her in the National Cancer Institute of Mexico, the INCAN, where I was living at the time. She didn't speak Spanish, but she didn't have any word, even in her own dialect, for pain, for the pain that she was feeling. This was just part of what she had lived all her life, and in the last years related to fulminating cervical cancer. But that day, she was going to receive support and care to deal with her pain and to get access to palliative care. And that began to convince us and teach us that there was a way to close the global pain divide and to fix the tremendous abyss that there is in access to palliative care overall. We decided to map and to present visually what the pain pandemic looks like. You see really two things on that screen. First, an engorged United States, Canada, and Australia. And second, the rest of the world disappearing. Latin America is tiny, India is a line, Africa is very small, Russia and China, the rest of the world disappears because what you're seeing on that map is access to pain relief medication compared to the need for that medication at end of life and for palliative care. The basic statistic to keep in mind is that the 50% poorest in our world have less than 1% of the opioid medicines to relieve their pain. But you have to contrast the pain pandemic with the opioid epidemic. Both are very serious. We lose patients to opioid use disorder in this country every day. But what you're seeing in that map also was the best case scenario for palliative care in terms of access to pain relief medication, because it doesn't include other needs, like, for example, surgery. And this, I can tell you as someone who has lived through 2 mastectomies. When I woke up from my first mastectomy, I had to decide whether or not it hurt more to breathe or not to breathe. Very, very luckily for me, thank God, the morphine came quickly, and I was able to get through the pain and agony of those days, and to be able to live my breast cancer alongside my family that supported me through it for the months and years that were needed. But it taught me a lesson that many patients have to deal with. They choose between suicide and pain. And that we learned, for example, from one of the leaders in palliative care, Dr. Rajagopal, who has made access to palliative care his cause in India and particularly in Kerala, and has done incredible things to close the global pain divide. But Raj's testimony that he shared with us as a physician was having helped one man who was in tremendous pain to get access to morphine. And yet, there was a stock out the next week. The patient came and the patient said to Raj, "If there is no morphine next week, I will hang myself from that tree." And he picked the tree. And Raj says that he knew he was serious, and that is the sort of choice that patients make all over the world. But what about their family members, their loved ones, the professionals who give them care? They're not lucky enough to have what I finally had when my father was dying, which is access to a humane way to support their loved ones or the patients they're caring for to alleviate their suffering before death. So what do? They're faced with an inhumane choice, the choice of watching their loved one die in pain or doing something that must be illegal. That is ending badly. It's not ending well. And it guarantees that there will be complex grief for those who survive. And again, that is the reality in our world. So how do we solve this? And there is a way to do it. And we call it access without excess, or a balanced approach. And there are countries in the world that do this well, even though the United States clearly does not. Germany, for example, has very, very low rates of opioid use disorder, yet very ample access to pain relief medication for those who need it. So what do we learn from the case in the United States? Is the message, which is being pushed forward all the time and is behind denying access to pain relief medication for the poor, is the message to deny the poor this medication? Isn't that the same as saying that starvation is a cure for obesity? This is not the way to solve this problem. But we have, as a commission and around the world, thought of ways that this can be relatively easily solved. And the key is access to off-patent, inexpensive, frankly cheap, oral and injectable morphine. One of the reasons why we don't have it is, in fact, because it's so cheap. Nobody wants to produce it because there is no profit. But the lack of a profit motive is the key to ensuring that there isn't overuse and abuse. There's no reason to have an illegal market or to push a substance when there is no profit margin. Now, when I say cheap and inexpensive, it truly is. Our estimates of the cost to close the global pain divide in terms of medicine is about the budget of a mid-sized hospital in the United States for 1 year. And a piece of data that always sticks in my mind, because sometimes I'm asked, if you had $1 million for global health, what would you do? Well, $1 million is what you need to provide the pain medication to all the children in low-income countries that need it, $1 million. But shoveling out the medication, especially when we're speaking about medication that does have risk and is addictive, is not the whole answer. It needs to be coupled with specific interventions to give it the safety that it's required. And at the core of that are adequate human resources and training. And we mean for all those individuals who are engaged in palliative care, from those who are faith counselors to those who are specialty physicians. But at the core, what we've seen at the core of it are nurses. And we have examples from countries where nurses are able to lead the way. One of them is Uganda, with incredible results by empowering nurses not only to be able to give and transport the medication, but to do the prescribing once they are well trained to do so. This is how you close the global pain divide. But one of the other things that we've been missing all along is the way to measure the value of doing so. In global health, what we measure is premature mortality, stopping people from dying, or ensuring they're not sick. But we never measure the value to people of not being in pain or suffering. And I'll give you the obvious way to think about this. How much would you be willing to pay to go to the dentist for a tooth extraction with or without numbing medication? Right? The vast majority of us will say a lot, but we don't measure that. So when we give metrics and we think about priority setting for our global health leaders, they'll never think about alleviating suffering or access to pain, and that's what we see in global health. So there's a lot for you all to do. There's a way to push forward these solutions. And at the core is just to care about the suffering and pain of the poor, which most people don't think about. There are organizations around the world that do this well, and they need your voice behind them to generate and be part of the conviction that giving access to pain relief medication is not pushing an opioid epidemic, but guaranteeing justice. Organizations like the International Association for Hospice and Palliative Care, the Worldwide Hospice and Palliative Care Alliance, or the very important International Children's Palliative Care Network are all struggling to close this global divide. There's a lot of discussion now in the world about what is a wicked problem. And a wicked problem is one for which we don't have a solution. And for many of the things that I work on in global health, the problems are wicked. But the pain pandemic is not one of them. The pain pandemic has a solution. What's wicked about the pain pandemic is that it continues to exist and be a problem, one that can be solved, and again, with your help. And now I'll end with this one image, which is very important to me. When I work in some of the places I work in on a topic like this, hope is sometimes lacking. And so I keep this image in mind, and I'll share that this woman, now 21, who's in that photo, is here in the audience. In my last dose of chemotherapy, I got septicemia. And that was the one time when I said goodbye to her in the morning where I didn't know if I would see her again. And yet, thanks to the amazing care that I got from my physicians in Mexico City, 1 week later, we were in Toronto at a butterfly farm. Now, bald was not necessarily beautiful for her. It was hard to deal with even with a hat on until we got to the butterfly farm. And then I became the focus of her attention because all the butterflies landed on my turquoise hat, which we still have. And I keep that image close to me and close every time I present because we cannot forget our need for hope when we search for ways to be able to solve problems as important to the poor as is closing the global pain divide. Thank you very much.